All right. Good afternoon. My name is Dr. Yair Kielson. I'm a hematologist, medical oncologist, as well as a palliative care physician. We have the privilege here today to hear about coordinating geriatric care and medical needs. We have two speakers. Our first speaker is Dr. Maria Carney. She is you can see the bios in the book, but just to shorten it, she's the Chief of Division of Geriatric and Palliative Medicine and Medical Director for Post-Acute Services at Northwell Health, as well as the Hofstra Northwell School of Medicine. She's dedicated her career to promoting longevity and advocacy for needs of an aging society. And I can attest to that most of the patients in the hospital now are in their 90s. She has published in the area of dementia, advanced directives, and other areas as well. Dr. Liberman will be our second speaker. She's Associate Chief of the Division of Geriatric and Palliative Medicine and an Assistant Professor of Medicine at the Zucker School of Medicine of Hofstra Northwell. She's very involved in the clinical operations as well as the research areas and has been continually working to broaden exposure of palliative medicine to the continuum of modern medicine in both oncology and heart failure initiatives. Without further ado, we'll do about 20 minutes each speaker, and then we'll have time for questions afterwards. And if you have one index card, you can fill out the index cards, and I can ask the question for you.
Great. Thank you so much for introducing me. Very nice. And for having me here today. I'm a geriatrician. I trained at Cornell for internal medicine and then Mount Sinai for geriatrics, and I've been working in the Long Island region for most of my career. My clinical work is outpatient geriatrics in Great Neck on Northern Boulevard, and I have some brochures here that I can share with you if you would like that. So I wanted to really speak about my talk will be really about society and aging society and how with that come the caregiving needs and coordination become much, much more difficult. And just out of interest, those that are here, who's here personally challenged by this? Right. And so I'm happy to help discuss whatever your needs are afterwards, but I hope it'll kind of give perspective. You're not alone, is basically. This is many people, and including myself, are dealing with this in our own personal lives, and then I see it from a professional point of view. So, and this can be informal if you'd like to stop and ask questions as we go or wait till the end, whatever you want. We have a small enough group here that it can be very flexible. So we're going to talk about aging population, life expectancy, how it's changed over the last century. And so the changing landscape of aging and what is a caregiver and why we are in a caregiver crisis in the United States. So this is a moving graph. This looks at the population from under 5, the percent of the population from under age 5 to over 80 from 1950, and it moves. We're now 1985, 1995 year increments. And in 1950, we were a much younger population. And as now 2015, 2020, you'll see that baby boomers are becoming over 65 now. And what we all have, the silver tsunami, some people have heard, the baby boomers becoming over 65. And then by 2050, the fastest growing population is the over 80 population. And why has this happened? Any thoughts?
Medical health is better.
Medical care, medical health is better. Okay. So one way to look at it is mortality has declined, right? And this is a slide from Bloomberg data, and from 1968 to 2014, I believe, every age group we have over 85 in the purple, broken down to below 25 in the green. Every age group from 1968 to more present has declined. Their mortality has declined. And we've improved health care, longevity, life expectancy, mostly in the under 25 age, but even in the over 85 population, mortality has declined. We've done a really great job. And if you look at the this is the United States. Now if you compare the United States in red with other countries, we look at life expectancies. We're not unique. Other countries too have had an increased life expectancy over the years. And then the bottom shows health expenditure, healthcare expenditure. The United States spends a lot more on health than other countries. And maybe not as high of a life expectancy of some other countries. I'm not sure why, but that's recent data. But either way, life expectancy has increased over the last 50 years. So what's happened is that we've seen progress in decreasing mortality from breast cancer, prostate cancer, heart disease, stroke, HIV. So healthcare has improved in addressing the prognosis and making certain diseases that, like HIV, has now become a chronic disease. Breast cancer has made progress. And an unintended consequence of improving care in these diseases is we're seeing individuals living with dementia. And this is just another slide. What do you notice here? This looks at health care expenditure in blue and social care in the green, or teal, by countries. What do you notice?
U.S. spends the most.
On healthcare. And who spends the least on social care? Right.
How do you define social care?
So social care is caregiving needs, as opposed to pharmaceutical care, hospitalization, doctor's visits. So, but that's a good question, how it's exactly broken out. But I think housing might be part of that, also social care. I'm not saying this is right or wrong, I'm just saying there are differences. So, in my work as a geriatrician, I see that outcomes and benefit of individuals who are living longer with multiple illnesses, our treatment options really depend on the ability or access to having caregiving, a caregiver in their lives, in your life. So what does a caregiver do? What are some of the things a caregiver, and now there's terms, people are using care partners because they're part of the healthcare team, right? What do they do? What are some of the responsibilities or tasks? How do we define a caregiver? What is it?
Usually the family member in proximity to the aging parent or another relative, child parent.
Right, it usually is a family member, right? It falls onto a family member or is the responsibility of a family, and often is one person that does the majority of the caregiving. So caregiver from the nextstepsincare.org is someone who's responsible for the care of someone who has poor mental health, physical health, disability, or whose health is impaired by sickness or age. It's someone who takes care of someone who has a chronic illness or disease. Okay? What are some tasks that a caregiver does?
Coordination, everything. You just hold it together, making sure you're eating, getting to the doctor, getting the transportation, the insurance, psychosocial, buying them the cookies that they like.
You sound like a caregiver.
I do advocacy professionally and on my mother's
Right.
Alzheimer's.
Right. So you see it both professionally and personally. Right. So there's what we say activities of daily living. You said the feeding. We also say dressing, personal care, bathing, toileting. But it could.
I think it runs the gamut of crisis management. There's a situation which you can call drop everything to ongoing trying to put things in place. And
Right.
sometimes throughout and not those places.
That's a good point. There's the day-to-day function and then being available and ready to respond to crisis management. Right? And well, let's see how we did. So it could be start as like, oh, I'll start getting some food, right? Shopping. They're having a little, individual maybe having more difficulty doing their chores that they used to do, so you start doing that. Then you start doing some finances for them. You're managing their medications, picking up the medicines, making sure it's the right medicine, bringing it home, making sure they are able to take the medicine, reminding them to take the medicine. You know, each task has a whole different layer of involvement, right? It could be more superficial or more intense. Taking to the doctor's offices, you mentioned that. And then this one, which is also very challenging, is communicating what happened at the doctor's offices with everybody else in the family or in the support network. And why wasn't that done? Why wasn't this done? Right? Wait, did you ask this? Right? So you're telling this, that communication is another level. Dressing, we talked about, bathing, toileting, feeding, and then being involved with or helping make healthcare decisions, whether that's formally or informally. And I now have to add another bullet on crisis management, so thank you for that. So caregiving and coordination is the challenging issue, and I just want to make a comment about care coordination. Is we live in an area of the country that really provides specialty medical care. That's almost the norm. For you and I that can go to different doctors, you know, we go to the orthopedist, we go to the neurologist if we have specific problem. But as someone gets more and more medical problems because we're living longer and we develop more chronic diseases, that gets very, very challenging for many patients themselves. They don't want to necessarily go to so many doctors, but sometimes it's needed. And it's very often difficult for families to do this. Many parts of the country don't have as specialized care as we do. We're fortunate and blessed, but it has a challenge to it. And the added challenge is that many of the doctors have a tough time coordinating amongst themselves and speaking with a unified voice. So I think that's what we do, is try to bring a unified voice to these multi-specialty care that is often part of people's lives. So caregiving today, most caregivers are family members, predominantly female, in their 40s to 50s, and a third of caregivers in the United States take care of 2 or more adults, and the majority are taking care of a relative. So it's a family responsibility. It's very stressful. There's often an economic hardship too. And most caregivers also work. The majority of caregivers are juggling their own families, work, and caregiving responsibilities. And the recipients of care are also mainly female, living in their own home. And
Is
only,
is that correct? The recipient's average is 61 years old?
yes,
Huh?
it's a spectrum, but yes.
Okay.
Everybody ages differently. Yeah. And only 4% live in a nursing home or 4% in assisted living. And many people in society think those are options, and they're not necessarily options for everybody. It's a small percent. So it's majority is in home. And most caregivers are taking care of someone who's 50 or older. And the duration of caregiving is almost 5 years. That's very different. A child born in 1900 was expected to live to what age? About 40, 45. A child born in 2000 expected to live to what age?
100.
About 80, depending. There are disparities, but about 80. So a near doubling of a lifespan in 100 years. And we asked why earlier, and you said medical care. What else happened in that 100 years, from 1900 to 2000, that has promoted longevity?
Utilization of professional health care.
Immunization was in there, antibiotics. Early 1900s, it was clean water, food preservation, refrigeration, preventing infections, then antibiotics, immunizations. Now we have injury prevention. We wear seatbelt helmets. We don't have injuries at work as much. So that's all contributed. So public health and medical care has contributed to all of that. So if you think about our generation who is providing care in this complex medical environment we all living, there's never been a generation that's had to provide and coordinate care like we are. If you think about your grandparents, people did not live to this age ever before, and with a duration of caregiving needs of 4.6 years. I think about my grandparents. My grandfather lived with us growing up. He had a stroke and he died. He lived with us within a 6-month period of time. But we are now able to do things medically that has changed that. So we really don't have experience, many of us, with some of the things we're dealing with in this caring at home for 5 years. So we're all in this, this is all new, basically.
Right, and I was saying, another thing also I know came up, my mother's a Holocaust survivor. So it was like so funny because when she was first diagnosed, she had the dementia, but she had this kind of added element, or the social worker said to me. And I did a lot of research just being in the industry, and like even people in the industry, nurses and doctors told me they had no experience with this because people never lived this long and the trauma was never kind of dealt with before.
Yes,
so
right.
It's very frustrating when there aren't answers like that.
There
For someone
are.
who's traumatized to begin with and then they're demented.
Yes, I've had the privilege of taking care of, and in taking care of several Holocaust survivors, and it is an added element of trauma that often comes out again and relived, and requires, an added level of respect and, but we don't know. This
Right,
is
that-
all
that
new.
was the
This is the,
frustrating- right.
So we are in a caregiving crisis, and when I say caregiving, care partnering, coordination, all of this together. People are living longer, and more are living alone. Harder to get to. I work in a suburban area, right? You have to have ability to drive or transportation to get access to all of the care that is available. We're just starting now to start delivering care into home, but it has not kept up with the need. The need is great. Delivering medications, delivering doctor's visits, etc., home care. There is a shortage of direct care workers in nursing homes, And while the care, there's a shortage of care at nursing homes, the majority of people are at home, and that is another added level. It's very hard to find care to assist. So many people go without any help that they need. The added complexity is the transportation I mentioned. And this is not just a family problem. This is an employer issue, right? If you think of Northwell Health, and we're working with our HR department because many of their employees have this responsibility and they take time out of their day to care for family as it is. So we have to think creatively, how do we address this issue and this challenge? And then as you become a care partner, it kind of falls on you, right? It slowly builds, sometimes more suddenly than others, but you may do the shopping, you may be doing medications, taking doctor's office, but then it gets more physical, personal care, and there's really no training or skill development available. You just have to, I don't know, did anybody here take any classes? Has
Why
anybody?
did somebody open courses? It's like,
It's true.
We need to.
Yeah.
So we're starting to discuss this with Hofstra School of Nursing, Hofstra School of Medicine, how to develop classes to help individuals. Just how to transfer somebody without hurting their back, or how to make a bed when somebody's unable to get out of bed. So we're talking, you'll learn here about what's available and coming, but we need, until you live in this environment, nobody knows. And there are people making decisions in society that don't understand what's in need. The need is going to expand greatly. So interesting, Emory University has a Rosalynn Carter Institute for Caregiving. They've actually made an academic center, which I would love to develop with Hofstra and Northwell. But their 5 steps are: develop and increase evidence-based caregiver programs. You have all the answers today. Improve quality for caregiving workforce development. So for those that are providing care formally or informally, improve the quality. Support family caregivers. We need to recognize, and Northwell is doing that with their own employees, that family caregivers need to have a little bit of support. We need to increase public awareness, so I thank you for letting us come and speak. And we need to enhance community care resource networks. Develop a place that you can call to help get what you may need. Or maybe you don't know what you need, but talk it out and say, I'm in this situation. One of the things we do in our office is, we have a social worker in our office of Geriatrics in Great Neck, is look at the benefits. What does somebody have already that we can activate or link? From Medicare, Medicaid, do they have long-term care insurance? Are they a veteran? What's available for home delivery? Do they qualify for Meals on Wheels? Can they get home health aid? Do they need infusions at home? Hospice services, pharmacy delivery. Are there community senior centers in their neighborhood that can be of assistance to free time for the caregiver to have a break? Are there adult daycare programs that they can do? Do they live in a naturally occurring retirement community? Could they benefit from an assisted living or a long-term care facility? So these are kind of the things we do in our office with our social worker to help us with them, while we have the medical care, social working care as well. So we need a solution to this caregiving crisis. We need to do a better job as physicians assessing the caregiving needs and abilities of a patient so that we can link our treatment options to what the patient and family need and are able to provide. We need to establish caregiving resource centers, and Dr. Liberman will talk a little bit more about what's available. We need to increase our multidisciplinary or interdisciplinary teams to help individuals with multiple chronic illnesses so that we can try to provide the right treatment and expectations in care and help people along their journey. We need to start creating and using innovative resource support and programs, and then we need to study the impact. So Dr. Liberman is going to talk about what are some of the resources and support. Do you have any, you can either leave questions or take any questions now.
Thank you. Thanks, Maria.
Thank you.
So, Dr. Carney has really laid the foundation as to where our country is going in the sense of how we're growing older and growing older with more chronic diseases. And we just sort of decided that we should put together some of the things that we as a health system provide and are working on providing in the future so that we can help support the caregivers and the patients and families. So some things we'll talk about today is our post-acute services that we are provided, which entail our rehab centers, our long-term care, some of the home care, the Northwell home care, hospice care, the innovative procedures that we're doing, especially at Long Island Jewish Hospital, where we're identifying older adults and families who could get resources in the community without being admitted to our hospitals. How we have engaged our patient and family-centered teams, including volunteers who really help significantly in caring for our patients. Some support groups, some technological support that we're looking into, and how to having conversations about what patients and families want and where they want to be. And then sort of how are we going to grow this. So we are not just hospitals. Everyone drives by Northwell, LIJ. We do have a lot of robust care that's going on in the home and in the community. We have a growing physician ambulatory services that are providing some of these multidisciplinary teams that can help you support patients and their families. We have acute care services, including those hospitals, and then post-acute care services, which include our rehab centers and our home care services. So we see this a lot. I'm sure, unfortunately, a lot of us have lived this world where we have a loved one who gets admitted to a hospital and then they're discharged, correct? And then we are sort of stuck with what do we do, right? And it's very confusing. It's very, it's almost like a maze. I feel families struggling through this every day. We do luckily have a lot of great support in our communities that can help you through this transition period. And this may be your new norm. It may not be. We don't know. But we hope that we can provide you with some of these services along the way. We have subacute rehabilitations with long-term care, Stern and Orzac. Broadlawn, we actually are, I think we sold. We have a really robust home care services that goes under noted, and that does support a lot of our families through the transition from a hospital or from a rehabilitation center. And then we do have a very robust hospice service as well, whether it's in-home or in an inpatient. We are really proud of our rehabilitation services and long-term care, Stern and Orzac, which get a 5-star rating. Nobody ever says, I want to be admitted to a nursing home, right? That's actually, everybody, if you asked, I want to be home, right? And actually there are national surveys that say when I'm really sick and chronically ill, I want to be home. But as caregivers, just as Dr. Carney spoke, it's really hard to sort of get into that transition period of a new norm for them, whether they've had a stroke or they've had a chronic illness that has now debilitated them so that they need this support. And we're really proud of the care that we provide patients and families, and so that we can then transition them to wherever they need to be, whether it is home or with long-term care. We also have a very integrated home care network. Specifically, we actually serve over 40,000 patients annually, which in a daily census of 5,000, which is pretty astonishing considering, how much actual home health aides and nurses that are provided to do this care. It's really hard, and I'm sure as families you recognize that. We have the ability to help with home health aides, and I know a lot of this day-to-day activities of daily living, dressing, bathing, transferring. It's really hard, and we need a little bit more support. We want to be loved. We want to be the family, but we can't always be the person who actually does the care. And so we have that opportunity to help find you patients and families from home health aid. We actually do a lot of things at home that don't need to be in a hospital, right? The hospitals are bad places. Nobody wants to be in a hospital. I mean, I work in a hospital. I don't want to be in a hospital all day long, especially as you're older and you're frailer. Right? Better being at home. And so a lot of the things that we're trying to do is stay in the home. Antibiotics at home, IV fluids at home, feeding tubes at home, giving medications at home, high-tech nursing at home. We have patients on ventilators at home. We have a lot of opportunities to provide care at home so we can limit the stress of being in a hospital. Right? Being in a hospital is stressful for not only the patient but the family as well. And then we are also lucky to have, if somebody is at the end of their life, the opportunity to care for them in their home, the support of hospice, either in their home or in an inpatient facility. I'm very proud of the work that we've done here. As I stated, I really am very stressed when a family member gets admitted to a hospital because it changes the norm of the caregiver and the patient. So we were provided a grant to allow to see if we could identify older adults in our emergency room at Long Island Jewish Hospital. What we were allowed to do was hire a social worker who spent probably the first 3 months of her time just identifying the community resources, Meals on Wheels, day programs, elder care attorneys, visiting MD programs, anything that they could find that could offer support to families and their loved ones to stay in their home. And so we identified the patients that were at high risk of being admitted and thought, can we send them back without being admitted to the home as a community resource? And we did decrease this after 2 years by 32%. And what we really found was so exciting was that really what we noted was that what families really needed was a geriatric navigator, a navigator who understand what the community was. It really wasn't even the getting them out of the hospital. It was really just the wonderful support that they now had. They could call them back. They had a number to speak to if they ever needed any resources in the future. And so we're hoping that we can expand this across the health system so that as our aging population grows, there is people in our emergency rooms who are specialized at understanding what is in the community and how we can get them back into the community in a safe way. We've also really worked with our volunteers and patient and family-centered care because they're the ones that are going to help our caregivers, cope with what is going on. And they understand. They are part of the caregiving world. So we've worked with a HELP program, which is Helping Elders in Life program within the hospitals. We've done things in the surgical waiting room. We have a geriatric and palliative care team in all of our hospitals across the health system. We are working to create geriatric emergency rooms where they're more geriatric friendly with people like a geriatric navigator in order to understand what resources they need in the hospital and the community. We try to engage all of our patients and family in different support groups, and you can go through all of these different support groups, but they're out there, they're just not navigated well. And so I think that we really struggle, and we find is our caregivers are just struggling navigating this maze of what's going on. And so we really are trying to figure out how we can sort of streamline these issues of patients who are dealing, and family members who are dealing with chronic illness in the community so that they don't have to wait to get to the hospital to find out what's out there for you. And that is sort of what we are seeing more and more. We are providing patients and families devices to stay at home, things like, and I know a lot of family members have memory loss and maybe getting in and out of bed and may have a risk of falling, things like a mattress so that if it goes alarm, if they get up, they'll know the family members can get up. We have things that can track things on the computer now, medications that tell us when they're supposed to be able to take their medications. Just a lot of devices out there that we are providing our loved ones and families in caring for these chronic illnesses. A lot of what we do is in our outpatient practice, and we are trying to expand this across the area. We are a division of geriatric and palliative care. We are located in Northern Boulevard, and we are a multidisciplinary team because the reality of this, none of this could be done without the specialties of a physician, a nurse practitioner, a pharmacist, a social worker. It is complex, and your family may need one thing more than another. And so we're really looking to sort of expand this type of multidisciplinary team to also other places in our health system, in the primary care offices as well. So like Dr. Carney said, what do we need to do? We need to really create the strategy. We need to get resources they're out there, but how do we navigate them? How do we educate our families? How do we create them? Which is, a lot of them are already created, but how do we find the resources that are out there and navigate them through our community and advocate, right? We need to be advocates, and if we aren't advocates for this patient population, no one else will be. And we are growing, and they're not going away. We're going to be older and more chronically ill, and we need support. And we all hope that together we can figure this out. Questions? Good.
Yes.
Yeah.
Okay. I just have a question. I don't know if this is the right forum or not, but it's just something I've been asking people for years, like professionals or advocates. So New York has a great thing with the ALP program, the assisted living program, but if you have dementia and you really belong, honestly, in a secure unit, which costs like $8,000 to $10,000 a month, but you can't afford that, which is understandable. The alternative, they're going to say people come in a long-term care facility, which is sad because they really don't need that.
Right.
So what I'm wondering is there any way to get all the data, like to advocate as a collective, to recognize that need and say we so appreciate your ALPs, but can you create an ALP floor? Like I know a specific assisted living center, I'd be happy to turn over one of my floors to that. Obviously, and they need to get more money from Medicare.
Right.
It just seems to me like such an obvious answer.
So I feel strongly about that I just don't think there has been while there's an awareness of dementia, it's been largely focused on research and cure, which is important, but I don't think there's been enough attention on the care for dementia. And so I'd be happy to be part of
I would
the
love to start a
creation of
movement as advocates.
yeah, there's not been a large strategy regarding dementia and in our society and what are the needs.
Right.
Well, not to take anything away from the needs of the research and the science to prevent the disease, we still need a strategy on what's best for the care. It's not going away. It is just starting. It's going to get worse. And and I totally agree. The resources, the available housing, it's just not there. We don't have it. And families need to speak up and advocate.
I want to thank you both for your presentation. That's excellent. I did what I call a full-time son. For a growing number of years now.
Yeah.
You're motivating me to realize what I'm saying. What do you see developing in terms of support, caregiver support groups? Have you seen any emerge lately?
Yeah, so I mean, I think that there's a lot of buzz around this right now. We're seeing a lot of people who are interested in creating caregiver support for health systems. We have a very robust one in Phelps. We just opened a wonderful one out in Peconic Bay, and we are looking to create that over in central Queens, Nassau County, of a resource center of hope support groups.
What is Phelps?
Phelps is up in Memorial in Westchester. We recognize that this needs here, and so do people here, and so that is our mission for pretty much 2018.
Fundamentally, though, caregiver resources, caregiver support have to be philanthropically developed. It is not supported, not even through Medicaid.
No, right? There's nothing. Medicare doesn't have a.
It's not funded. If we could build to hold a caregiver support group, we'd have many more. I mean, I'm just being realistic. But our social worker in our office, she hosts a caregiver support group for dementia out of Zucker Hillside Hospital. We do know of many other disease organizations like the American Cancer Society.
They have one at
support
Montrose
group.
Center.
Parkinson's disease organization, I forget the formal name, they have another support group. So those are often references and resources for families and caregivers. But the reality, it has to come from philanthropic support. So we are hoping to expand, and we welcome partnering with people,
Anybody.
but that's a challenge.
You mentioned, part of this for long-term care hospitals and rehab is to get trained workers, to get staff. So the result of it is that things can go wrong. So my question is just to name, since I advocate for a few people who are in rehab, what would be the top, just to mention a few areas where someone who's advocating has to watch out that things shouldn't go wrong medically.
So I always say turnover. I find when staff turns over, that is when you should recognize to look for something going over. Turnover, like if not shift times, like if your loved one or a family member is in a long-term care facility and they've had a home health aide or a nurse there for 6 months, and then you see that they're gone, that would be the time that
That's a danger point.
That's a danger point. That's the type of question you're asking. Yeah. That is a concern for me because, and we see a lot in our nursing homes because unfortunately they don't get paid a lot. They're taking care of many patients and many families, and patients who have especially memory loss become accustomed to who's caring for them, and when that care changes, our worry is that patient who's in the will change as well. So that's something I would look at. What other things?
You make the point that this is work, home health aides, certified nurses aides. This is very demanding, physically demanding work that doesn't really have a ladder, career ladder, very easy. It doesn't. Like sometimes, we need to make it feasible that a home health aide, that maybe they can get into a nursing program a little bit easier, so that there would be a job to start and be inviting to. But it's hard work with frail, vulnerable individuals that are complex, and it's really a thankless job. So I always like to say, if you have someone that's doing good work and you value, just thank them.
Right.
That's more of a proactive thing.
Yeah.
Because it's hard.
I also think just if you're going to be in a long-term care or an assisted living, people look at star ratings. That we say how wonderful, but I always say it's where you can be.
People look at.
These star ratings. They have 5-star rating. They're wonderful.
How valuable are those?
So they are valuable in the sense that they have to go through a very rigorous evaluation by the state, and so there are certain levels that are very. But what's most valuable to me, and I tell this to all my patients and families and my own loved ones, is if you could be there on a more consistent basis, that's where you should be. So if the nursing home or the rehab center is a block from your house and it has a 3-star rating, that price is probably better than the 5-star rating that you're never going to get to. Because it's just you being there and putting your eyes on it is so important because you're the partner.
Does Stern do long-term care?
Because WISAC does not.
Yeah.
I'm a social worker at a hospital. I know very well that.
Stern has a very
WISAC, like the cute old lady man, they will go home in 2 weeks.
right. Predominantly Stern and Orzac are subacute rehab centers. There
So
are
that's
a
one,
few
though.
long-term care beds available,
Yeah.
but
But it's easier for them, just so everyone knows, it's easier for them, and they are excellent, like, we always tell people that they're excellent, but it's easier for them to have a 5-star rating than a long-term care facility, which, you develop bed sores and you're there for certain amounts of time, like, it's just, there's certain things that are automatic, that is just, so people should just know, like, stars are only as good as
Right.
stars, but meaning, it's kind of a little bit like a hit or miss kind of situation. I tell people, like, even if a place has, as you said, 1 star, it could be that might be the best match for your loved one.
Right.
If you're there, or if it
Right.
works for you, or
Exactly.
it's such a hit or miss.
Yep, 100% agree.
Yes. Do you take phone calls from out of your neighborhood? I'm in Brooklyn, from time to time, I felt like I could use a navigator.
Yeah, so our home care, post-acute, home care referral line can get you in touch with a navigator. Now, the senior navigators for post-acute services, if you formally want them involved, there's a cost to it, but they can potentially help you with certain questions. I will say that Maimonides has a geriatrics division. Barbara Paris is the director and vice chair of medicine there that I'm happy to give,
I didn't try it, it's fine.
She's wonderful.
wonderful. It might be a resource for you.
Mm-hmm.
One final question?
Do navigators have to be social workers, or like what kind of training do they get? Or it's just like kind of experience and they learn what, like how can they help you?
So the navigator that I was talking about in our was more just a term that we called. It was really a social worker with just expertise in providing resources in the community, and she did a lot more other than just getting them into the community. She did psychosocial support and assessment. But in general, navigators are usually not social workers, and we see it a lot in the oncology world because they sort of navigate them through, like their surgical doctor, their medical oncologist, like when you're going to get to the lab. So a navigator is usually somebody who just sort of navigates you through the system and does not need to have any degree other than just understanding the system that they're with them.
Specifically look for social
Yeah,
workers.
yeah. No.
Formal geriatric care managers, sometimes they're RNs,
Mhm.
social workers that tend to be the background people have as a geriatric care manager. But not necessarily.
Not necessarily.
Do you have brochures or cards that?
We have cards and brochures too. Yeah, we'll be
Thank you
there.
very much, Dr.
Thank
Carney and
you.
Dr. Liberman.
Thank you very much.
Thank you.
Please feel free to go up to the 5th floor where all the vendors are there displaying their services that may help you.